Hi, my name is Bhatia-Lin, and I am a current internal medicine resident at the University of Washington. I developed this video to explore how race changes our interpretation of pulmonary function. These are the learning objectives. In this video, we will discuss the history of spirometry, the development of race-specific and race-neutral reference equations for spirometry, and clinical implications of a switch to race-neutral reference equations. The idea of racial differences in pulmonary function predates the existence of tools to measure lung function. Thomas Jefferson listed potential lung structural differences among other defining physical attributes that set enslaved Black people apart from white people. He argued that these differences justified continued enslavement of Black people. It wasn't until the 1840s that a spirometer was developed in the UK by John Hutchinson, marking the first time lung function could be objectively measured in large groups of people. Following this, Samuel Cartwright, a Virginian physician and enslaver of Black people, built his own spirometer and used it to quantify the difference in lung function between Black enslaved people and free white people. He referenced Jefferson's argument that Black people consume less oxygen to explain the 20% difference in lung function he calculated between Black enslaved people and similarly sized white people. At the end of the Civil War, Benjamin Gould wrote a book surveying the bodily characteristics of Black and white soldiers. In a chapter on lung function, Gould reports a difference in mean lung volume between Black and white soldiers that persisted when adjusting for height. He did not adjust for age or environmental factors. This data was used during Reconstruction and into the 1920s to argue for white supremacy, notably by Frederick Hoffman to explain increased mortality in Black individuals after emancipation. Based on studies such as these, the medical establishment incorporated race correction factors and then race-specific reference equations into pulmonary function testing. The interpretations of PFTs using these race-specific equations have been used for decades to make management decisions for patients. In the modern era of precision medicine, new generations of clinicians absorbed the practice of using race-specific equations as being data-driven. There's not much thought about the reasons for categorizing people by race, nor about the impact of doing so for pulmonary function testing. Now let's examine race-specific reference equations in more detail. The equations that are currently most commonly used were developed by the Global Lung Function Initiative in 2012. These reference equations were based on a heterogeneous group of people who were not known to have respiratory disease and did not smoke. Their analysis resulted in equations being developed for 4 populations: Caucasian, Northeast Asian, Southeast Asian, and African American. These curves demonstrate the population-specific regression analyses for FVC by age for men for each of these 4 groups. The mean fitted FVC is shown. Unfortunately, a large swath of the world's population, including the African continent and Indian subcontinent, were excluded due to lack of data. The GLI data was similar to prior data in that it showed the FVC of Northeast Asian men was 4 to 6% lower than white men, and the FVC of African American men was 10 to 15% lower than white men. This data was used to develop the GLI race-specific reference equations for pulmonary function testing. In 2017, the American Thoracic Society recommended using these population-specific GLI spirometry equations based on self-reported ancestry. Prior to that, other race and ethnic-specific equations or correction factors had been used. When an individual gets pulmonary function testing, their results are compared on a normal distribution matched to their age, sex, and height. This generates a z-score based on the standard deviation of the population that indicates how far away a value is from the mean. The z-score is used to determine when patients have abnormal lung function. Z-scores below -1.645 are below the lower limit of normal and indicate likely abnormal lung function. Only 5% of the reference population is expected to have a z-score lower than -1.645. The GLI race-specific reference equations match individual results to race-specific normal distribution. So how do we make sense of the differences seen between populations in the GLI data? Samuel Cartwright and others concluded that the discrepancy in lung function between races indicated a biologic or genetic difference between races. However, we now know that race is not a proxy for genetics. It is, in fact, a social construct. Instead, we should consider that the differences may be an effect of exposures and life experiences that vary between people of different races. For example, we know that environmental factors like early childhood exposure to pollutants and infections worsen lung function. and we know that these exposures vary between racial groups. On average, Black people in the U.S. are more frequently exposed to these factors. Perhaps environmental and social exposures are enough to explain the lower lung function among Black and Asian populations. Including race in reference equations normalizes the idea of biologically innate differences in lung function between racial groups. This leads us to ignore the underlying structural inequalities that are likely driving these differences, instead of working to improve them. Therefore, there's been a push in recent years to move towards the use of race-neutral equations, which would unmask the health consequences of social inequities for certain populations. In 2023, the American Thoracic Society recommended the use of a race-neutral equation, GLI Global. This reference equation was developed using the same GLI 2012 dataset as the race-specific equations. One average equation for the whole dataset was developed by weighing the contribution from each of the groups so that smaller populations contributed more to the equation than they would have without the weighting. However, the strategy still excludes Africa, India, and South America, and critics note that these racial categories were chosen without a clear justification. This is a complex issue. While we cannot anticipate all the consequences of switching to race-neutral equations, let's explore some of the clinical implications. This study compared the use of race-specific versus race-neutral reference equations for Black and white patients. In these graphs, the number of individuals categorized as having obstructive, restrictive, nonspecific, and normal pulmonary function testing is defined by the width of the green and red lines. Lung function interpretation changes when the race-neutral equations are used instead of race-specific equations. The green lines indicate resolution of respiratory impairment, and the red lines indicate new respiratory impairment. For white individuals, the race-neutral equations mostly led to resolution of nonspecific pulmonary impairments, with some results being reclassified as obstructive. For Black individuals, the biggest change was in the number of normal individuals reclassified as having a restrictive impairment, almost 10% of the cohort studied. The same study showed that application of race-neutral reference equations led to reclassification of the severity of disease for both Black and white patients. For Black patients, there is an increase in severity of disease. This study illustrates the significant interpretation impact of switching from race-specific to race-neutral PFT equations, which will be most profound for Black individuals. The implications of this are complicated. You can imagine situations in which race-neutral equations could alleviate health disparities, and situations where race-neutral equations could worsen health disparities. For instance, race-neutral equations are likely to increase the number of Black and Asian people who are evaluated for ILD and who are eligible for treatment. However, using race-neutral equations may decrease the number of Asian and Black people who are eligible for lung cancer resection. This study demonstrates the impact of reference equations on lung cancer surgery recommendations. In this study, 225 thoracic surgeons were given a clinical vignette of a 71-year-old woman with a right upper lobe non-small cell lung cancer. They were randomized to one of three groups receiving a different percent predicted postoperative FEV1 value. This value is used in clinical guidelines for lung cancer treatment recommendations. While the value of FEV1 in liters was the same, the percent predicted varied depending on reference equation used. Surgeons either received values calculated with the GLI Black reference equation, a race-neutral reference equation, or the GLI White reference equation. All percent predicted values were between 30 and 60%. Within this range, recommendations are not clear on the optimal management, and so the surgical approach varies. The primary outcome was treatment recommendations. Surgeons recommended lobectomy, wedge resection, or radiation therapy. Lobectomy is considered the only curative treatment for lung cancer. The study found that surgeons randomized to the White reference equation were less likely to recommend lobectomy than those using the Black reference equation. This group was more likely to recommend wedge resection or radiation, which have worse clinical outcomes for patients. Untangling the clinical impact of race-neutral versus race-specific reference equations will be an ongoing issue, especially given the March 2023 American Thoracic Society recommendations to use race-neutral reference equations. In this video, we reviewed the history of pulmonary function testing. We learned that race has been used in pulmonary function testing due to both racist beliefs regarding the physiology of Black enslaved people and studies like Benjamin Gold's Survey of Soldiers in the GLI 2012. Arguments that Black people had intrinsically worse lung function were used to support slavery and argue against civil rights for Black people. We also learned that exposures to stress, pollution, and poverty might explain racial differences in lung function. These exposures differ due to structural inequalities between races. Rather than accepting that certain racial groups have intrinsically worse health outcomes, we should move towards addressing the social, economic, and environmental drivers of those outcomes. Finally, as we move from race-specific reference equations to race-neutral equations, patients of all races will be affected. Their access to care and eligibility for treatment may change. We will need to be thoughtful about how institutional change may impact individual patients based on their race. Thank you so much for your attention. This video was developed with the guidance of Drs. Rosemary Adamson, Nirav Bhakta, Aaron Bao, Laura Granados, and Neha Deshpande. This list of recommended reading provides more information on race-specific reference equations.